Okay, Chapter 8, Essentials of Psychopharmacology and Treatment of Mental Health Disorders. As you read through the chapter, keep the chapter objectives in mind, be able to describe the different settings in which mental health services are delivered, discuss the basic classes of drugs available to treat mental illness, discuss the different phases of drug development, and finally, discuss the salient features of different schools of psychotherapy. Okay, so treatment settings can vary from institutionalization, where you're actually admitted and kept in an institution, to receiving treatment at home. The setting is determined by the severity of the issue. The setting is finite. It may change as the person progresses through their treatment plan. So again, in professional diagnoses, if they feel that you're a threat to yourself or others, or maybe just require a very intensive treatment program, then institutionalization may be an option, because that's going to be the safest way to deliver treatment and monitor your progress. And you may be able to get to a point where you're discharged to receive treatment at home once you've kind of stabilized your symptoms. Okay, so the high cost of treatment supports the idea that wealth is health, right? So if you have resources, then you should be able to achieve certain health ideologies. Whereas it should be your health is your wealth, right? Your health should be the resource that you draw upon to get satisfaction. But we are kind of locked in with a healthcare system that is driven by resources. You can't get away from that. The problem is, without supplemental government programs to, equalize the availability of resources to receive treatment, that's always something that we are struggling with. Can be voluntary, involuntary. So voluntary just means that, hey, you recognize the problem and you kind of admit yourself, say, look, I think I'm going to need some help with this. Involuntary, that should be, it should only be available under the most dire conditions, right? We always want to preserve a person's freedom and liberties to choose what's best for them. But there may be situations where, again, there may be threat of harm to others or to the individual themselves, and that this kind of requires us to, or someone to intervene and kind of get the treatment process started. A milieu, okay, that term means it's a structured group, meaning that the membership is carefully selected to create a therapeutic social group in an attempt to create appropriate social norms or expectations, with opportunities to role play and develop the skills necessary to overcome psychological issues, right? So the therapeutic milieu, again, it's more of a peer-driven group that kind of allows people to kind of work out what's appropriate in various social circumstances, so that, again, they're able to, their treatment plan include not only their own individual treatment, but also looks at how they can transition back into society in the most comfortable way. Okay, community-based treatments authorized by the Community Mental Health Act of 1963 creates outpatient mental health centers as an alternative to institutionalization, right? So institutionalization, the problem with that is that you are removed from society while you receive treatment. And then once you receive treatment, you're going to be returned to society. And you want to minimize, if you want to minimize what a person loses in terms of the familiarity, how to act or react in various social settings. So these community-based treatment settings make treatment available and accessible in a community setting rather than an institutional setting. Okay, so while outpatient mental health is the most common, partial hospitalization may be necessary when close supervision is needed, or the person needs a stable treatment location because home life may not support the therapy. The person may be homeless. You just don't know what their situation is. So partial hospitalization just creates a setting that's conducive to their therapy without having to be fully admitted to an institution. Again, we're trying to get away from the use of institutionalization unless it's a very severe condition. Okay, with safety concerns due to their issue would not be suitable for partial hospitalization. They would require much closer supervision or monitoring. Telemedicine and telepsychiatry are both gaining popularity due to convenience they offer. If you can eliminate driving to and from your appointment, waiting in, sitting in the waiting room, and all the other things, you can regain all that time back by communicating online with your personal health care provider. I've incorporated telemedicine into a lot of my routine visits, doctor visits. It's we accomplish all the same things, except they don't measure my height, weight, and blood pressure. But you can certainly do those things at home, report those to your telephysician, and they can update your records and so forth. So it's been a really a convenient type of thing, and I can see telepsychiatry offering the same types of convenience. Also, by eliminating some of the challenges, you may be encouraging more people to seek psychiatric help that would otherwise not seek it because of the challenges involved with setting up appointments and all that sort of thing. Okay, one of the things we constantly keep in mind is for resources to be available and accessible. Another reason not listed here is how remote consultations can be less threatening. Okay, so I'm talking about telepsychiatry, especially if someone perceived their mental health issue to be stigmatized, right? So the person may have thoughts, well, if someone sees me walking into this building, they're going to know that this building is for mental health treatment, and therefore they're going to know that I'm seeking mental health. That may not be the case, but that may be what's going on in the person's mind. So they may see telepsychiatry as a way to avoid that situation, and it works as a viable solution for them. So again, not saying that this should be the only form of mental health treatment, but I think it's a viable form of mental health treatment in some cases. I believe that all of healthcare will have some type of online presence. As it's stated on the slide, it will take a while for telepsychiatry to gain mainstream utilization until insurance and credentialing organizations figure out how to function in the virtual space. Some of my physicians that, I have telemedicine appointment visits with, they've been able to kind of work out how they bill and are reimbursed through insurance through that, where I have some other physicians that either they're not interested in kind of pursuing that, or they just haven't received the appropriate approvals yet from their billing departments to charge for those types of visits. So the future is, I think technology, everybody has a device that they carry around with them. That device can avail itself to many resources that are out there, and I just think that it's how the world is moving towards more virtual and online delivery of things. All right, so take a note here. The text mentioned randomized clinical trials are needed. I just wanted to discuss why RCT was mentioned. So RCT is commonly used in medical research. to isolate the effect of the intervention and control the effects of confounders. Right? So confounders are variables that they're influencing the outcome variable, and they're outside of what we expect to be influencing the outcome variable. So in this case, we're looking to see do interventions help with mental health outcomes. Right, and we're trying to isolate. So if there is an improvement in mental health outcomes, we can go back and say, oh, what's due to the intervention. Well, there's a number of other things. Confounders can be, having appointments visit during the day versus the night. Right, maybe there's some difference there. You don't know until you run the analyses, but confounders are variables outside of the expected independent variable effect on the dependent variable. So the transition to telepsychiatry can be promoted relatively easily. Like I mentioned before, I was an early adopter of telemedicine. And the main reason for that, I suspect for one physician, because they're so far away, it saves me probably 2 hours out of the day, travel back and forth, waiting in the waiting room, the visit itself. And I'll take that any time, that time saving. So I think we're going to see the same in telepsychiatry. Okay, in certain dire situations, a person may be admitted to treatment without their consent. This is a big deal. Think about if you were in that situation. Nobody wants to be forced to do things that they don't want to do. But again, it just depends on the situation and the threat that is present in order to make a determination that the person needs help, whether they agree to it or not. As such, any threat of harm would be a condition to exercise this option. However, we must continually reevaluate the individual. The goal is to return autonomy as soon as it's safely possible. Right? We want to give the person back the freedom to kind of live their life, but we want to reserve that until they're kind of stabilized and they're in the right frame of mind to make those types of decisions. Okay, another tool to help rehabilitate someone with mental illness may be to prescribe various medications to help manage the physical manifestation of mental illness, so the physical symptoms. Depending on how the physiology is being disrupted, an appropriate medication may be able to reverse or manage the issue, right? So, if we're dealing with something that it's a sympathetic nervous system impact, we can prescribe some CNS depressant or something like that, sedatives to help the person maintain a physiological homeostasis so that they're in the right frame of mind to receive their cognitive behavioral therapy. Okay, so mirroring advancements in medicine, mental health treatment has expanded parallel to advances in science. So again, as science advances, technology advances, our understanding of health issues advances, and therefore our treatment approaches are evolving as well. Okay, so psychotropic medications are in 4 classes: antipsychotic, antidepressant, anti-anxiety, and mood stabilizer. Okay, antipsychotics are appropriate to treat psychosis, right? Remember, that's when people lose touch with reality. They hear voices, they see things, hallucinations, those types of things. Off-label use is when the therapeutic has shown benefit, but has not been studied specifically for that benefit, right? So the person may be taking a therapeutic for one reason, but they're showing improvements in areas that we aren't really associated with that therapeutic. And if enough cases start to appear, then you may start to see some off-label use for that medication. Okay, so once a diagnosis has been made and an antipsychotic is prescribed, the physician must monitor the patient very closely until the dose has been worked out. So typically they're going to dose you at the lower level, and they're going to slowly increase that until you start to see the effect. They don't want to go too high because there could be side effects that come along with the higher doses. Right, and here are some of the side effects. And those side effects can be severe. That's why close monitoring is so important until the dosage is established. This is why you don't want to take on, or you don't want to have this idea that, okay, well, the physician prescribed 1 pill a day to manage my symptoms. So on pretty rough days, I'll just take 2. No, again, you want to do so under consultation with the prescribing physician. Development of antipsychotics has led to second generation or atypical, which are better at managing side effects but having much higher costs, which may be prohibitive, right? If you don't have the resources to get your hands on these second generation antipsychotics, then you're not going to see any benefits from it. Okay, antidepressants vary according to their mode of action, but SSRI and SNRI are very popular therapeutics. So I talked about this before. The serotonin reuptake inhibitors and the serotonin norepinephrine reuptake inhibitors. Basically, your brain's releasing these neurotransmitters, and when the need's over, right, the neurotransmitters are recalled. What SSRIs and SNRIs do is they allow the neurotransmitters to be available longer, and they can exert their effect longer. So kind of manipulating the physiology of the individual. Okay, anti-anxiety, also called anxiolytics. Medications vary by mode of action. So these 3 classes, either the beta blockers, the benzodiazepines, SSRI, SNRIs. Mood stabilizers help minimize wild mood swings that are typical in bipolar disorders. Okay, phases of drug development. So in order to bring new drugs to market, there's a series of steps that must be undertaken, and usually begin with animal models. Phase 1 studies utilize healthy individuals for the purpose of establishing tolerable doses, right? So once the animal models conclude and deemed to be safe on the research animal, then in these phase 1 studies, they start to administer really low doses and slowly increase it. What they're looking for is basically cutoff point where the reactions to the substances change, and what dose are those, and a lot of data is being collected. And phase 2 brings in affected individuals, and the efficacy and side effects are collected. So in phase 1, these are individuals that are relatively healthy, and you start to dose them with the new drug, and you're looking for side effects and any reaction. In phase 2, you're bringing in individuals with conditions that the new drug is purported to treat, and now we're evaluating, well, how well does it treat those conditions? Okay, so phase 3 begins once the risk to benefit ratio is deemed sufficient, by expanding the subject pool and continuing to collect data, right? So phase 2, everything went good. Okay, well, let's open this up to more individuals, increase the sample size, collect more data. And then phase 4 is basically a surveillance program. So once the therapy is brought to market, they continue to collect efficacy data, side effect data, but now understand it's opened up to a much larger pool, right? The consumers are getting their hands on it, and they have the data available. Okay, so the book presents many different therapeutic approaches. Just go through those, just get familiar with them. I'm not going to read all the slides available to talk about these therapies because, like I said, the book does a good job at concisely covering all of these. Let me get to. Okay, so newer approaches. So new approaches are born out of advances in technology, right? As science increases, our understanding of what's going on increases, and therapies kind of become more available because the lacking technology is now present. Kind of do these things. So transcranial magnetic stimulation. This is a non-invasive use, right? So we're not penetrating the skin or anything like that. We're just using magnetic fields to stimulate areas of the brain to treat depression and schizophrenia, right? So at some point we've mapped out the brain, we've detected what regions are responsible or impacted by different conditions. And if we stimulate those areas, it produces a therapeutic effect for those conditions. Okay, brain science has been an area that's receiving attention from many health fields. Mapping regions of the brain to various symptoms has led to deep brain stimulation and vagus nerve stimulation. An implant is used to provide electrical. So the transcranial magnetic use magnetic waves, and that can be effective in certain situations, maybe not in others. So in this case, they're actually implanting a device that can produce an electrical charge, and there's going to be a controller somewhere. Same type of idea, right? The area of the brain has been identified as being responsible for this condition, right? So that's where we're applying the stimulation. And then finally, there's a lot that goes into eye movement, desensitization, and reprocessing therapy. But basically, it's based on rapid eye movement as a sign of mental processing. And the therapist teaches the patient how to recognize issues that trigger stress and to apply the appropriate measures to manage the care. So basically looking at eye movement, if there's a rapid kind of shaking, teaching the individual to recognize, hey, that's a precursor to something that's happening. So you want to kind of pause and start to address that issue before it advances to something more serious. Okay, so like I said, go back and read up on those therapies in the chapter, and that does it for chapter 8.